people would have other commitments. So before I begin my session, I just want to say I have made these slides to the extent as easy as possible because we have people from different, understanding different backgrounds. Somebody have come from pharma, some are from device. So, and if you have any doubt, if it is relevant, irrelevant, don't feel shy. Just let me know. We will try to get your doubt clarified to the best level possible. If not, I know some TAVI experts, your questions I will take to them and try to get it clarified. So, but please do not hesitate. Don't think here, is this relevant or in this forum, should I ask or not? Just feel free to ask questions because this is your time. Okay. So I'll just share my screen and we'll kick off.
Rajan, can you get on a full screen, please?
1 minute, 1 minute. Yeah, that's what I'm
Sure.
seeing. Screen. Can you see my screen now?
Yes.
Yes, yes.
Tower basic science, this slide is visible.
Yes.
Okay, great. So this is basically today what we are going to cover is the structure of the aortic valve. Like because once you know the structure, then I'm telling you it is very easy to communicate with your interventional cardiologist and about the valve selection, about the patient selection, because these things you will be communicating very frequently once you receive the TAVI and once you receive the 3mensio. So before understanding 3mensio, if you know what are the things where they look into the 3mensio and what are the things and what are the structures which are important in a 3mensio, if you know this, then 60% of your job is done. You are already in the like you have gained the 60% knowledge. Another 40% will depend on your three knowledge, which is a process which will come as in when you are getting CDs, we will discuss them. And as you discuss with the cardiologist, you will get more questions and clarity. So once you know the anatomy well, then it's like very easy to understand the three-dimensional report. So this is for our internal distribution only, which I have made very. I have tried to cover the maximum points which are required for how to diagnose a case and the different types of aortic valves and what are the anatomies, what are the challenges, what are the cases which you should reject at the initial level, because this is very important when we are launching a product. We are the ninth company in India today, so all eyes are on us because we have an electrically retrievable system. So while selecting a case or while selecting a patient is very important, we choose the cases where we see there is less amount of chances of failure or any kind of complications. So I have designed my training in that way, and we will proceed that. So before I begin my presentation, a hats off to this guy, uh, Alan Crebier, who actually performed the first transcatheter valve implantation in 16 April 2002 in France. Unfortunately, we lost him last year on 16 February 2024. So he laid the foundation. He's called the father of TAVI. And he actually made it possible that even without an open heart surgery, he was the first one to implant a balloon valvoplasty in a patient. And he was the first one to deliver a balloon expandable valve, a valve crimped on a balloon. Although the procedure had some 50% complication, but still he laid the foundations of whatever evolution we are seeing is a modification of what this man actually gave to the world. So and he has he brought a revolution in the interventional cardiology business in the world. And that's why we all are talking about TAVI, different kind of valves, and today this procedure is gaining popularity. Now, today what we will be discussing is the structure and the function of the heart. I'll not go deep, just cover, just to brush up the basic structure. Then the aortic valve, anatomy and its importance, the femoral access, aortic stenosis, and other important technologies along with the 3mensio report. Okay. So if I'm fast, just let me know. I'll go slightly slow. So the structure and function of the heart to begin with. Now, as we know, the heart has got four chambers: right atrium, right ventricle, left atrium, left ventricle, and this is like a if you see this video, the right side of the heart will always receive the deoxygenated blood, and the oxygenated blood will be received by the left side of the heart, the left chambers. So it's like a two-way process. And if you talk about the, because we are talking about structural heart today, our focus will be on this aortic valve. So our structures, what do you call it, is something like we will be concentrating more on this aortic valve, which is present between the left ventricle and the aorta. So the other valves are like the pulmonary valve, the tricuspid valve, the mitral valve, and the aortic valve. So today we will be talking about aortic valve, because this is one of the most important valve. Because if this valve is disease and if left untreated, the chances of mortality goes from 30% to 50%. So before we begin, the valve status. Now, these are the two kinds of pressures which we all know. If not, then I'll just explain systole and diastole. So during the systolic phase, the pulmonary and the aortic valve will open, and the mitral and tricuspid valve will be closed. So systolic means is the contraction, and the next phase is the diastole phase. So in diastole phase, the pulmonary valve and the aortic valve will get closed, and the mitral valve and the tricuspid valve will open. So it's like a on and off, like it's like a contraction and expansion, which we call uh, systole and diastole. Now, the importance of this systole and diastole is very important when you are measuring the aortic valve. So, and I want this session to be interactive. So, can anyone tell me, should the measurement should be in systole, or should the measurement should be in diastole? Anybody? If it is wrong, also it's fine.
Sorry, Rajan, I didn't get your question.
I am asking, while you are measuring an aortic valve on an echo or on a CT, the measurement should be in systolic phase or the measurement should be in diastolic phase?
Mm.
mean,
This is
you
a
want to
tukka,
say
but it should be in diastolic.
I suppose it's diastole, Rajan. I don't.
Yeah, so it should be in systolic phase, because why? In systolic phase, the valve is completely open. Can you see this? The valve is completely open. So if you are measuring in a diastolic phase, you may undersize the valve, or you may undersize your measurement. So your 3mensio report has to be mandatorily in a systolic phase. So systolic phase is the phase which will give you the exact measurements. If it is a diastolic phase, then okay, there are some different measures to get to the valve size. But always remember, your 3mensio measurements or any CT or any echo measurements will be accurate only if you have measured them in a systolic phase. Because systolic phase, the valve is completely open. There is no chance you can undersize this valve. Is it clear, or any doubt from here?
No,
It's
but
clear.
systolic phase is supposed to be contraction of the heart,
Yes.
and diastolic is supposed to be relaxation of the heart.
Relaxation.
So you want to say whenever the heart is in systole, the wall is fully open.
Yes.
Okay. Okay.
Because when it is fully open, only you can measure this entire circumference. This entire measurement will be accurate only when it is in systolic phase, because the leaflets are opening. Because this valve has got three leaflets. I'll come to the anatomy, but understand, if the leaflets are completely open, then only you will get the exact measurement of that valve. If it
Okay,
is
so
closed, you may undersize it.
Rajan, Pratik here.
Yeah.
It may be relay with the contraction because it is pumping the blood that time. Okay.
Yes. Yes. Yes.
So during pumping the blood, both will be open, pulmonary and the aortic valve. So
Correct. Yes.
that we can rely on where the contraction happen and both has to open.
Yes. Yes.
okay.
So that's
So
what
basically the LV is contracting and then wall gets opened,
Yes.
and I think blood goes through the aortic arch. So I think at
Yes.
that time it is better what I get from Rajan is saying.
Yeah. So when the valve is when the in the systolic phase, then there is a contraction. Your valve will be open completely to
Hmm.
flow the blood from LV into the aorta. So that time only you will get the real measurement. That's what I'm trying to say.
Okay.
Okay. Is it clear, or should I
Yeah.
repeat it?
No
All
clear.
are fine with this?
Clear, sir.
Because why I'm bringing this, because so that you can correlate when I'm explaining you a 3mensio report.
Okay.
Okay. So for time being, you just understand all measurements of a 3mensio report or a CT or a echo has to be in a systolic phase. Okay, is it fine?
Yes.
Okay.
Yes.
Now this is the conduction system. I'll not go much of deep into this, but this is important because this is like the heart contracts and expands as per this. It is a sinus atrial node, then AV node, bundle of his Purkinje fiber. So this is a circuit, and there is a chance that during this TAVI implantation you may disturb one of the bundle branch if you go deep. Anyway, just for timing, this is just like conduction system of the heart. You remember once I explained you 3mensio, we understand this better. So this is like a conduction system. It is like a automatic contraction and expansion happening through a electrical pulse from the sinoatrial node to the AV node, AV bundle, and Purkinje fibers. And this is your normal ECG wave. P wave is atrial contraction, contraction of the ventricle. QRS is ventricular contraction, and T wave is ventricular relaxation. So any abnormality observed in this, we all know is a abnormal ECG, may be related to heart or coronary arteries or structural heart. So this is just a basic of the conduction system. So this itself is a big topic. Our focus should be only on today, TAVI and the aortic valve. Now coming back to our main topic, aortic valve. So if you can observe, this valve is opening and closing. Can you observe? I'll just play it once again. So this valve is closed. So this has got three cusps. This is a non-coronary cusp, this is the right, and this is the left. Can you all observe this? And in between these three cups are separated by these three lines. These lines are called commissures. So you have got three cusps. From the three cusps, there are three leaflets which will open and close, and they are binded with each other through commissures. So this is called intercommissures. This is called intercommissures. I'll just play it once again so that you can easily observe this. So this is how a valve will look on an echo. The contraction and expansion will be seen on a 3D echo. This is how the aortic valve will look in the cross section. Any doubt in this? Three cusps, three leaflets, opening and closing, separated by separated by the commissures. Any doubt in this? Because this is very important. Unless you understand this, the next step you will not understand. So let me know, and then I'll go to the next slide.
Yeah, it's clear.
It's clear. Anybody else?
Sir, it's clear.
Okay.
Clear.
Now, anatomy of an aortic valve. So, what in aortic valve we see? We see the left ventricular outflow tract. So, left ventricular outflow tract is below the annulus, 1 to 6 mm below the annulus. And then we see the aortic annulus, which is a ring formed by when all these three leaflets join, they will form a circular ring, which is called the annulus. Then we have the leaflet and the cusp, sinus of Valsalva, sinotubular junction, and ascending aorta. So let us understand in deep what are the each, because these all measurements you will observe in a 3mensio report, and this will determine whether your case is suitable or not, apart from the femoral axis. But these things are very important. They will ask you what is a measurement of the annulus, what is the measurement of the LVOT, left ventricular outflow tract, the leaflet, sinuses of alpha, sinotubular junction, and ascending aorta. So this anatomy you have to by heart. I'll not say by heart, but try to understand. Keep this picture embedded in your brain. The picture on your right hand side, which I'm showing. Because if you have this picture in your brain, then it is very easy to analyze any case, or it's very easy to analyze any report, or even when you are in a cath lab, it is easy to understand at which junction the valve is and what junction they are releasing the valve or they are retrieving the valve. So Aortic annulus is a transition point between the left ventricle and the aortic root. So this red line, can you see? So this is a virtual ring which is formed by the imaginary joining of the three leaflets. So when these three leaflets are joining at this bottom, they have given his name as the annulus. Now this annulus size is very important because this annulus size corresponds with your valve size. So if I say I need a vita flow of 21 means the aortic annulus should be 21 when I am implanting the valve. So it will make the annulus 21. Or when I am telling it is 24, so we are slightly oversizing. So after the valve implantation, the aortic annulus diameter will be 24. So aortic annulus directly corresponds with your valve size. So the accurate evaluation of this diameter is very important to decide the correct valve size. Now suppose why it is important means, suppose if I have done any mismeasurement, if I have selected a 24 valve and the actual measurement is 27, so the valve will not fit. It is likely to get popped out or it will deep down. So the measurement of this annulus is very important. So whenever we say 24, 27, actually this is a measurement of the aortic annulus. Is it clear or should I repeat once again?
Okay.
Just let me know.
So Rajan, just want to ask ki, is there any safety margin when it comes to size selection?
Yes,
Ki,
yes. So
hmm,
usually in self-expanding valve, you can up to 15 to 20% you can oversize. You
okay.
can oversize up to 15 to 20% because the self-expanding nitinol will exactly take the shape of the valve. No, because all aortic annulus will they look circular, but they are not. They are elliptical. Like there are some shapes which are not completely circular. So those are called elliptical annulus. So your valve will go and exactly take the shape. It's like just like say the water take the shapes of the container, correct? So
Hmm,
your
hmm.
valve will exactly take the shape of the annulus. So we have to do a 15 to 20% oversizing to get a good effective orifice area. Because if more the
Okay.
effective orifice area we will get, the more durability of the valve will come. So, anyways, that is a different subject. As of now, you just because in the interest of the audience, I'm telling
Hmm.
annulus responds to your valve size.
Okay.
Okay. Any doubt? Anybody has? Please let me know. And if I'm fast, also you let me know. I'll go slightly even more slow. No, if it is a relevant, irrelevant question, also I'm fine because this is something a science which is coming up, but this anatomy is going to be the same. So have you understood the annulus now? Annulus is the transition between the LV and the aorta, and it is formed by the imaginary line. When all these three cusps, RCC, right coronary cusp, non-coronary cusp are joining, they will form a circular ring, and this is called as your annulus. This corresponds to your valve size. So I hope there are no questions or should
It's
I move
clear,
on?
Rajan. It's
Okay,
clear.
fine. Now, this is very important. Left ventricular outflow tract, which portion of the left ventricle from which the blood enters into the aorta. Now, this is the landing zone of your device. You understand? This is the landing zone. Why? Because here, once this annulus will be selected, the proximal or the inflow section of 2 to 3 mm will go into the LVOT. Okay. So this is very important because this is your landing zone. And as you go up, your pedal will be released in this area. This is the ascending aorta. So this LVOT, this is purple line you can see just below 3 to 4 mm depth. So this is what this is the landing zone. So this is important. Why this is important? Because if you go more deep, suppose if you go 5 and 6 mm deep, if your valve dips down more, you are likely to hamper the bundle branch and patient may go for a pacemaker implantation. So that is why the importance of LBOT is very high because the depth of the LBOT will decide the success of the procedure. So sometimes, most of the time, it is equivalent to the aorta, 3 to 4 mm deep, but and some cases it is small, it is large, depending. Again, there we will discuss this separately. LVOT is a different subject. But as of now, you just remember this is the landing zone of your device. You have to keep your device 3 to 4 mm deep to avoid any kind of pacemaker implantation. Because in LVOT, just before this 3 to 4 mm, there is a muscular septum. So, which is you will see in the 3mensio report. So, once you give the 3mensio report, you have to give the length of the septum. So, this is like a vertical distance from this. From annulus to 4 to 5 mm deep, the septum usually starts or usually ends. If you go below 5 to 6 mm deep, then you are likely to hamper the bundle branch and patient may go for a left bundle or right bundle blockage leading to pacemaker implantation.
Rajan, Pratik here.
Yeah.
We are separately discussing about the balloon expandable valve where the brady implantation is slightly low as per few operators. Okay.
Uh-huh.
So anything related to this, what you're speaking?
Yes, yes. So, because
Why?
all
And
tall,
also one thing,
yeah.
is it really the balloon expandable valves are less brady implanted ratio?
Yes, yes. So earlier, what was happening when this balloon expandable valve has got a very short frame. Okay. So they go minimum deep into the LVOT. This is one thing. The tall frames were diving deep into the LVOT because when you are releasing the valve, suppose you are mismatching the size or due to suppose there is some miscoordination between the first and the second operator, and once you are finally releasing the self-expanding valve, it goes deep down. It will hamper the branch. So that's why they have developed a cusp overlap technique. We will come to later on it. So to answer your question, less with the balloon expandable earlier because of the short frame, the brady sizes were less. Now we have equivalent because now we have modified our implantation technique. It is the same with the self-expanding also. Because earlier physicians were not trained how to use a self-expanding valve.
So related to this, so what you try to explain it in balloon expandable, the operator has more control on the implantation of the device compared to self-expandable.
No, it is not about the control. It is about how confident you are placing your device. So balloon expandable, what happens? The force is very high. Suppose if there is more calcium in the LVOT, you cannot use a balloon expandable valve because the balloon will expand with a certain heavy pressure, and because of the longitudinal pressure, you are likely to hamper any left or right bundle branch. But if there is no calcium in LVOT, then you can easily go for a balloon expandable. So it depends upon the operator, how confident you are, how deep you are going. Because earlier people were trained on balloon expandable, self expandable came little late. So it is about the operator, how skilled he is in, placing the device or anchoring it at the annulus.
Okay. Okay.
So as of now, you remember, just in the interest of the audience, please don't
Okay.
get confused. This is the landing zone. You have to keep it 3 to 4 mm deep to avoid any kind of pacemaker implantation.
Okay. Thanks.
Any doubt anybody has got?
No, sir.
And please ask questions यार. You should not be मैं रामायण के जैसे बोल रहा हूँ आप लोग कुछ बोल नहीं रहे हो तो फिर I want more interaction. If it is you understood, it is fine. If not, then let me know. I'll try to explain this by giving some other example. But please feel free.
So Rajan, the best way would be you form your own questions and you put it back to the audience.
Okay. Okay. Fine. So these are the three leaflets, like as I told, the right coronary cusp, the left no coronary cusp, and the non. Okay, cusps are nothing but spaces, and these are called sinus of Valsalva. So from the right coronary cusp, we have the right coronary artery. From the left, we have the left coronary artery, and this non-coronary cusp is placed posteriorly. So these are the three cusps. So can you see this area which is bulged like this? Can you see my cursor? This bulge.
Yes, yes.
This is the sinus. So this is one sinus, the second, and one is posteriorly. And from, if you observe from this end, one artery will come, which is the right coronary artery, and from this side, the left, and this non-coronary cup is placed posteriorly here. So it's like a combination of 3 cusp and 3 leaflets. Okay. Now the sinotubular junction. So now we have understood the annulus, we have understood the sinuses. Just that. So as the aorta goes up, it becomes in tubular shape. So this is called as the sinotubular junction. It is the transition of the aorta from the sinuses into a tube shape, and this junction is called the tubular. Can you see this tube like? You see this purple line exactly when it adds green. This is becoming in tubular shape. So this is called as a sinotubular junction.
Yes.
And then as we go up here, where your pedals are released, this area is called as ascending aorta. So please by heart this design, because if you know annulus, down LVOT, sinuses, sinotubular junction, ascending aorta, your understanding of any 3mensio report or any anatomy becomes very easy. So please by heart this design. You have to by heart or explain or keep it embedded in your brain. So as per my understanding, if you by heart this, it's very easy to understand, or keep this image in your brain whenever somebody is explaining you regarding annulus. You know, oh, this is the annulus. Here exactly the anchoring will happen. This is LVOT, with this is the landing zone here. This is the sinuses. From the two sinuses, two coronary arteries will be there. And this is the sinotubular junction and the ascending aorta. So this is exactly our, what do you call, aortic root anatomy. If you know this, it's very easy to understand 3mensio. It is very easy to understand a tower procedure. So can somebody tell me now, what is an annulus? Or what is the importance of this annulus?
Pratik here, Rajan.
Yeah.
Annulus is basically the transition point between the LV and the aortic root.
Correct. And this responds to your tower size.
Yes, that is more importantly where we correlated with the TAVI sizing.
Yes.
Dr.
Can
Rajan,
somebody, yeah.
Is there any significance of this size of this sinus of Valsalva for this TAVI sizing or choosing the wall?
Yeah, so there is a compliance chart which will tell you what should be the size of the annulus, what should be the size of the LVOT, what should be the size of SOV, STD, ascending aorta. There is a compliance chart. That compliance chart will decide whether you can do this case or not. So usually your sinuses should be 2 mm more than the your annulus. So suppose if you are having a 21 mm valve, so ideally your sinus should be 23 or 24. It should be 2 to 3 mm more, so that it can accommodate that valve, and the valve frame can expand very properly, and there are no chances of any coronary occlusion.
Okay. So that's the significance of this, considering the size of these sinuses.
Yes. So based on the sinuses, you may have to decrease your valve size, or you may have to increase your valve size.
Okay.
So that is a separate subject we will discuss when we are doing a case selection.
Yes, because I always have confusion regarding why this size of sinuses, they are so much important. Annulus we can
because
understand.
sinuses are important because the most bulky portion of the valve is going to get placed here. Okay. So one portion will go deep into the LVOT. As you go up, then this bulky portion will be accommodating the most widest part of your device. And then if you see beta flow also, before it's a tubular valve. So one portion is tubular. As you go down, the size is it has widened, and then again it will go deep into LVOT. So this is the most widest portion of the aorta. So that is why this has to be bigger than your annulus size always. If it is less, then there are different techniques and methods of doing it. So I don't want to confuse people. So as of now, you remember that sinus of Valsalva has to be 2 mm more than the annulus size.
Okay, got it.
Okay.
And
So
its height doesn't matter. Means from the annulus, the whole height of this sinuses, does this matter? Means
Yeah, that also matter. But again, the sinuses, if they are wide, then the height will not matter. What will matter is your coronary height.
okay, fine. Thank you.
okay. So Rajan, one little question.
Uh,
As we are speaking that the selection of the tower will be near about 2 mm more than what the annular size is, but it can vary due to calcification of the leaflets. Does it
yes, yes,
matter
yes.
then?
No,
Oh,
what 2 mm more should be no. Annulus size, अगर आप 21 का size ले रहे हैं, suppose you are
हाँ,
selecting a 20 mm device, so your
हम्म,
sinus of Valsalva should be 23.
okay,
It's not the annulus size. If the valve size is 21, your sinus of Valsalva should be 2 mm more than the annulus size, all the valve size, because you have to accommodate this in the most widest portion. If you see a Vita flow device, it will go and it will expand and again it becomes tubular. Okay. So your widest portion of the valve is going to get accommodated in this, right? So that's why this has to be 2 mm more than the annulus. This is a general rule for all the self-expanding valve.
okay.
Rajan, this is Suresh here.
Yeah.
In case of balloon expand in this condition,
No, come again. In case of
in case of balloon expandable,
no balloon expandable, it's so the frame itself is very short. So that SOV will not play a bigger role because your frame size is only it will come below the coronaries. So you know this, and anyways it expand at a very high pressure. So SOV size is not that great important, but yes, when it comes to self-expanding, it is an important feature. So that I will explain you when we discuss advantage and disadvantage of an SCV versus a balloon.
right, Rajan.
So hope I think with the anatomy we are clear now. You have an annulus, which is a ring formed by the when your three leaflet join at the base of the aorta. Downward you have left ventricular outflow tract, so your device should be placed 3 to 4 mm to avoid any kind of pacemaker implantation. Then you have sinuses of Valsalva. Then you have sinotubular junction as the aorta becomes tubular shape, and then you have ascending aorta. Till that, if you are clear, then I'll go forward.
Yes, doctor.
Yeah. Okay. Now, this is very important because we are living in Asia and 40% of these cases of in India are bicuspid valve. And here our importance, we are lucky to have a device which is specially designed for bicuspid, our Vita flow, because of the high radial force. So what is a bicuspid valve? Bi means two. It will have only two cusps. Bicuspid means only two cusps. So in bicuspid also there are subdivision as per the Seaver classification. So this is called as a type 0. There are only two cusps in this. There is no raphe, but there are only two cusps. There is a right coronary cusp and there is a left coronary cusp. So there are only two cusps which are, and there is only one commissure. Can you see this? So this is called as a type 0 bicuspid. Okay. Is it clear? The valve which has got only two cusps, usually aortic valve will have got three cusps. But in type 0, you will have only two cusps. So that is called as a type 0. Is it clear?
Yes.
Yes.
Now, type 1 will have three kinds of features. I'll go very slow and explain you. So you see, this is a right coronary cusp, this is non-coronary cusp, this is left. So whenever there is a joint between, a calcific joint between the right and the left, or the right and the non, or in the non and the left. So this is called as type 1 bicuspid. And this is called as a raphe. this portion which you can see is like, bold. This is called as a raphe. So 89% of the cases are type 1 bicuspid, the most difficult to treat in any, because this raphe will not allow the valve to open and your valve will be constricted. There are more chance the valve will pop out. It will pop out into the ascending aorta or it may go deep down. So this is very important, type 1 bicuspid, and 80% of the cases will be right and left type 1 bicuspid, where you will see there is a joint between the right and there is this raphe present between the right and the left cusp. So one is type 0, one is type 1, and one is type 2. This is very rare, where you will see two raphes, either between right and non, left and right and non. So there are 5 types of bicuspid, one in type 0, only two cusp, then the type 1, where either of the raphe will be there in either right or left, right and non or left and non, and then type 2, again very rare, but the most common will be type 1 and type 0. What I have observed in my 350 plus cases of TAVI is type 0 and type 1 are the most common ones. So in India, you will find more type 0, especially in a young patient, because congenitally only the patient will have only two cusp. He doesn't have a third cusp. And this type 1 will develop over a period of time, so that there is a raphe developed, this raphe develops due to the calcification between the two cusps, that is we call type 1. So for you to understand, always remember type 0 and type 1 are the most common bicuspid aortic valves. Any doubt in this? Because this is very important, because whenever your doctor asks in your report, he'll be keen to know whether it is a tricuspid or a bicuspid, and if it is a bicuspid, what type of bicuspid, because then accordingly they have to take precautions, they have to keep a backup stock equipments and all everything. So type 0 and type 1 are the most common ones as per the Indian population.
Rajan, can
Doctor
you
Sir,
just
good morning.
Yeah,
डॉक्टर साहब कैन आई आस्क यू वन थिंग आई एम मुकुंद बर्डे
yeah.
ये टाइप 1 में रैपे जो होता है उसके
Uh-huh.
बाद डज इट अफेक्ट बाइकस्पिड फंक्शन इन एनी वे
No. So what happens once there is this raphe, you have to break this raphe with a pre-dilatation balloon.
ओके
We'll break this raphe and then we will seal it with our new device. So anyways, the new device is obviously our valve is a tricuspid valve which we are inserting. So this raphe has to be broken
अच्छा
with a pre-dilatation. So you have to do aggressive pre-dilatation in such cases.
So this rapid develops on its own over a period of time in such
Yes, it develops
bicuspid
over a period
patients,
of time. Yes.
and then it further creates a problem.
Yeah. Because what
For
happens once this raphe is created, now you imagine all these three leaflets are opening like a lotus. So when this raphe is created means only so this portion is getting blocked. So between your
Right.
right and left corner, because this portion the blood is not coming out into the aorta. So this
Right.
again leads to aortic stenosis, because this raphe will grow, and this becomes like it will cover half of the both this cusp.
So then the blood flow automatically diminishes in
Yes,
such a case
yes.
to a very large extent.
Yes.
And the chances of this rapid breaking on its own is very less, or
No. Raphe cannot break on its own. You have to break it with a balloon with a pre-dilatation.
okay, sir. Yeah. Thank you, sir.
Rajan,
Yeah.
in type 1, only non-coronary cusp will open in this case?
No. So as I told, there are three types. One is right and left, which is 71%. Right and non, it is 15%, and right and left and non is 3%. So depending upon your where is your raphe, accordingly that portion of the leaflet will get blocked.
Okay.
Rajni, one question. This type 0 is congenital, but of course,
Yes.
but in every this bicuspid valve, this tower intervention need to be or replacement need to be done.
Yeah, that is a good question. So we need to see the what do you call the first of all the age of the patient. So
Okay.
sometimes what happens if the patient has a bicuspid since birth, and if he develops a rheumatoid infection that is called rheumatoid aortic stenosis, he may get it in early 30-35 also. So in those cases, you better to go for a surgical replacement.
Okay.
You have to do open heart. But
Open.
again, it is left to the cardiologist. They are doing in 40 years also. But
Hmm.
ideally, TAVI should be done. This is I'm talking ethical.
Hmm.
We are not, see, suppose for me, if any young patient comes and they want to do, I may also not say no because finally, it's the end of the day, it is business. But
Hmm.
if I talk ethically, less than 60 years, it is not worth to do a TAVI. Because
Hmm.
any TAVI you do today, after 10 or 12 years, the patient is going to come back. So in 40
Rajan, there is a clear guidelines of ESC, AHA and all. Doctors will do the procedure accordingly only.
yeah, that's what I'm
Hello.
telling. So
Yeah, there is a clear guidelines, ESC, AHA guidelines. They have a class 1, class 2, class B recommendations. Any patient less than 60 years of age at TAVI is not even in the class, not even in the third class. So nobody will dare to do that.
But Abhilash, if I tell you 40% of North cases are done in less than 50 years of patients, then
That may be, if it is Kawasaki disease, if it is, as you said, that, if it is a rheumatoid arthritis, if it is a Kawasaki disease, the patient is high risk for the surgical replacement. So there
no,
are special cases, surgical contraindications. Those
correct,
cases,
correct. Correct. So
there is no choice for them.
this is a topic I leave it to the doctor what they want to do. Because by the end of the day, because I am a businessman, I am a business manager, I need my business. Only thing it should be anatomically suitable. It should not cause any kind of annulus rupture because type 0 bicuspid will have lot of calcification at the annulus and also into the alveoli. So if you try to implant your valve, it may lead to leakage or it may lead to some kind of rupture or valve pop out or leading to a coronary blockage. So the center and the operator has to be first of all very experienced with bicuspid. So nowadays we have such centers, we have such operators. Regarding the age, I leave it to that institution because that they have to decide. And it is also sometimes the patient would not like to go for an open heart. They insist. I have seen in Manipal, though the patient is eligible for a surgical valve, still they don't want an open heart surgery.
Hmm.
They want what do you call? I want a
Correct.
TAVI
Correct.
because they
Hmm.
have tremendous. They want to spend money, even if they have to go for one more procedure after 10 years. They are okay. They are counseled. Their consent is taken in that way. So it is again guidelines are to be followed, but again it depends upon the morphology, the age, and to that particular doctor and the patient what they want to
That
do.
is what Rajan saying. If a patient is at the age of 40, he said, I am a Ambani, I wanted to do the TAVI, I don't have any problem.
Right.
As per the guidelines, it should not be do. It should not be do the. It's a duty of the cardiologist. He has to tell that, he will do that. They are doing accordingly only. You can find out there are here and there cases. Doctors will be doing TAVI for 20 years age also. But if a
Uh,
patient is, it's not a matter of affordability. It's a matter of the guidelines. How long, if you do a TAVI, how long, the valve is going to be survive for a 30-year of age of a patient or a 40-year of age of a patient. He may have to do a redo tower after 10 years. Okay, so that is why the guidelines are clearly saying guidelines are not at all depend upon the affordability of the patients. Guidelines are depend upon the mortality and morbidity of the patients. That is why even if it is the age of 40, if the patient is affordable, TAVI is not at all recommended. And if it is a sensible cardiologist, he will not do it.
so
Okay.
I will not
I
go
think we
into
are
the sense.
debating.
We are
Yeah,
debating a
Rajan.
topic which is
Ah.
Yeah, Rajan.
irrelevant, I think, here.
Hmm.
So
Yeah,
that's what
let's
I
stick to
leave
the
it to the
topic.
cardiologist.
It's a
Guidelines
separate
are there.
discussion.
We will do our work of telling whether anatomically it is suitable or not. Plus, you have to also see if the patient has got any other comorbidity. Suppose the last case which we got at Manipal, because just in the interest of time, I'll keep it very short. Last case which we got from Dr. Anand Chuna at Manipal, that patient had a lung edema. So they did an Navitor. the procedure went uneventful. There was no event. Patient died within 2 days because due to the lung edema, there was paracephalic that is the fluid collection in the lung, and patient died. So when we are selecting cases, especially in the launching phase, you have to see the anatomy and also if there are any comorbid conditions, because what will happen, the cardiologist will blame your valve because nobody knows what happens. The patient went home and he expired there. Now, immediately, if it happened within a week, slightly the chances may come has the valve performed, but he may have other comorbidities also. So that is very important to understand when we are initially selecting cases. Okay, anatomically it is fine, but what are the other comorbidity conditions which can hamper my patient selection? Anyway, regarding the patient selection, age and all that, leave it to the doctor. They have to decide. They are the best people. Okay, so in this bicuspid, any doubt anybody has got? Is it clear? Type
Dr.
0, type
Rajan,
1?
Dr. Rajan,
Yeah.
this is Kuldeep here. Just a
Yeah.
small clarification on this. This classification of bicuspid aortic valves which we have given, it is for the Asian population or it is in India also? Because when you
No,
see
this is a
in
global. This is
type
a global classification. This is a global classification. Sievers.
global.
Yes.
Okay. Okay. So India also the same applies,
Yes,
sir?
yes,
Type
yes,
1,
yes.
71%
That's what
is the
I'm telling. In India,
major
more
market.
are type 0 and type 1 cases, you will find more. Once you start getting the CDs, you will find more are type 0 and type 1 cases. Because if you see our study also, what the VitaFlow study, in that also 45% some patients are of bicuspid anatomy. So in Asia population as India, China, the bicuspid prevalence is more. And these are one of the most difficult cases to treat also, procedure-wise.
Okay, sir. Thank you.
So, Rajan bhai, so just want to understand, okay, this is a classification of the bicuspid aortic valve. So it's based on the cusp, okay, 2 cusp and 3 cusp.
Yes.
So in type 1 wrap, so there is already 3 cusps, na?
There are 3 cusps,
So
but
why it's fall down in the bicuspid aortic valve? What's the reason?
because the third cusp is not working. Only 2 cusps are working.
Okay, so it's a dependent on the functionality of the cusp. We
Correct.
differentiate and classify the depending on the things. So it's a basically function.
Yes.
Okay, got it.
Rajan, Pradeep here.
Yeah.
In the beginning of the discussion, we mentioned 40% of cases are bicaval. Okay.
Yes.
So, but when you look in here, it is only 6%. Okay.
So this is a global classification. They would have given some long back. But when it comes to Asia population, 40% you will find are type 1 and type 0 bicuspid put together. Because what anatomy we Indians, Asian, Chinese, Japanese we have more of bicuspid anatomy compared to the Europe and the US population.
India, it may not be 6%.
No,
Type
India
0.
is more.
Yes, okay.
Fine. So I think bicuspid, everybody is clear.
Yes.
Yes, Rajan.
Yes.
Okay.
Yeah.
Now you see, this is exactly how you train a 3mensio. So this is a tricuspid valve. So you have the right coronary cusp, the non and the left. Can you see these three cusps separately?
Yes.
And here you have only
Yes.
2 cusps. So this is a type 0 bicuspid. This is one cusp. This is the second cusp. The third cusp is missing in this. So that's why I have put both this to understand type 0 bicuspid. So type 0 bicuspid is exactly this will look in the CT and your 3mensio. This is one cusp, this is one cusp. And here you can easily differentiate the 3 cusps. Any doubt?
Hey, Rajan, the image on the left hand side, it shows E-cusp, right? But still you're calling this as a bicuspid?
No, this is the tricuspid. The left hand side is got 3 cusps. I have written, no, 3 cusp is normal. So this is a tricuspid valve.
Okay,
You can
okay.
see
वो
my
ऊपर
cursor.
में लिखा था type 0 bicuspid. So
That is
that's
because
what.
I'm showing here type 0 bicuspid here.
Okay, okay. So the left one is any which is tricuspid and the right
Yeah,
one is
and this one is
bicuspid.
bicuspid.
Okay. All right. Thank you.
Any doubt?
No.
Okay. Now, can you see this raphe between this RC and the NCC? Can you see this white raphe?
Right. We can
This is
see.
called as type 1 bicuspid, Dharmesh, that you were asking, no?
Yes, yes.
This is like so this leaflet from here, the blood will not flow properly, or there will be a hamperage. So this function of this, both these cusps will be hampered. So this is exactly the calcific raphe between
Perfect.
the right and the non-coronary cusp.
Perfect.
And for your reference, I put one more time, I put what is a tricuspid valve. So can you see this is non-coronary, this is right. So here there is no raphe, but here you can exactly see a raphe here.
Right.
Compare
It's a
both
very,
these images so you will understand.
it's a nice capture of the image. Thank you, brother.
So I think we are good with the bicuspid anatomy. Anybody has got any doubts?
It's clear, Rajan, clear.
Okay. Now these are the peripheral vessels. Why these are peripheral vessels? These are important because your femoral puncture, you will exactly take at this point.
Right.
At where there is a femoral head. So the abdominal aorta divides into common iliac arteries, then external iliac and femoral arteries. So femoral artery is the artery where will you take the puncture. Either it should be echo-guided puncture or a fluoroscopic puncture. So to be precise, can you see this femoral head here? This is the femoral head. This is a femur bone in the thigh and this is the head. So this point you have to take your puncture first for insertion of the sheath. So when I when I'll explain you 3mensio report, you will understand it better. So this is the right femoral artery. As you go up, this is external iliac artery and this is common iliac artery here. And this is the left hand side. So this should be more than 6 mm. Anyways, let's not go into deep. So just now for you remember, this is your puncture site. Puncture site should be in the center of this femur head.
Rajan, can you show the previous slide? Okay, thank you.
Okay. Anything else? Now, any doubt?
No, it's clear. So left side is, I think, a CT image, I think.
Yeah, this is a CT image, this one.
Right, perfect.
Okay, now understanding a 3mensio report. Now, 3mensio report is developed by Pi Medical Imaging, and the name 3mensio comes from 3 men because there were 3 people in Philips who developed this, and they formed their own global organization known as Pi Medical Imaging. And 3 men mean it's the 3 men who have developed. That's why they have named it as 3mensio report. So it's a Dutch-based company. Globally, everybody will accept a 3mensio report. Now they have developed and they update their software every year. And this 3mensio report first was only limited to cardiologists. Then, as the therapy advanced, the industry advanced, each therapy specialist today should know about a 3mensio report, how to prepare it, because this will lay the foundation for your case. So once you get a CD, the accuracy of the 3mensio report will define the success of your procedure. It is very important to understand the 3mensio report because if your measurements are mismatching in 3mensio, this is going to hamper your case. Because as I told you, like if your valve size was 27, you are measuring a wrong perimeter, then likely you will have to face the consequences. Or suppose the femoral arteries are less than 6, you have measured it more than 6. So it is again going to lead to femoral rupture or femoral complication. So your, what do you call it, the basis of any successful tower procedure, 3mensio is the base. Okay, things may go wrong while you are doing procedure separate, but the initial discussion will happen in the console room with the heart team is based on the 3mensio. So what are the usual questions the cardiologist will ask you when he sends you a CD or when he sends you a CT link? What is the anatomy? Is it compatible with your valve? So he will ask you whether it is a tricuspid or a bicuspid valve. First thing he will ask. Secondly, he will ask you what is the valve size? What are is your recommendation? Then he will compare with the other companies also. Anything I need to know additional, or what are the chances of pacemaker implantation? As I told you, the membranous septum, the measurement you have to give him. And what are the chances of PVL? If it is severely calcified valve, what are the chances of PVL? And are there any other anticipated complications which might occur? So everything, your 3mensio report should mention all these measurements. And if there you have a slight doubt that this may occur wrong, you have to mention it in your report. Because suppose tomorrow the membranous septum is very short, you know that patient may require a pacemaker. Inform your customer or your intervention or your operator well in advance, but to keep a double chamber or a single chamber pacemaker ready. Or if you feel due to some portions of the femoral arteries are calcified, the femoral artery may rupture, you have to ensure you keep a covered fluency stent in the cath lab. So in case there is any femoral rupture, they can easily implant a self-expanding covered stent there to close the distance. So this is why I'm telling 3mensio report will give you all the basic information about what is the valve size, and what are the anticipated complications, and which route either you should take a left femoral artery or right femoral artery, and also the what is the angulation of the valve or what challenges an operator may face during the course. So accordingly they are prepared well, right? And also finally the size of the balloon needed for pre and post dilatation. Now this is very important, because suppose your annular size is measured in two axes, one is the minor axis, one is the major axis, and that will give you an average. So suppose your annular size is 18, is minimal, average is 20, and maximum is 21. So your balloon size should be 18 or less than 18, so that you may not rupture the valve during the pre-dilatation. Should I repeat this or everybody is clear? Because this balloon is very important, sizing of the balloon for pre and post dilatation.
Dr. Rajan, can you just repeat that?
Yeah, suppose your minimal annular size is 16, 16. Average is 18 and maximum is 20. So you have to take a balloon, either 16 mm balloon or less than 16.
Okay. Yeah.
Okay, so usually all balloon will start from 16. I don't think there is any 14 mm. 16 is the maximum there, 16. So anyway, size is what I'm telling is your pre-dilatation balloon size should depend on the minimum diameter of the annulus. So idea is not to cause any rupture or any damage to the aortic annulus. Is it clear?
Yes, boss.
Yes.
Now, if at all, after the valve implantation, the valve frame is constricted, it is not expanded properly. So your balloon should be as per the average size of the annulus. So suppose the average size is 18, so you have to go with the 18 balloon. You cannot go with the 16 balloon, because you have to ensure the valve expands properly. So again, this also depends. I leave it to the cardiologist. This is what our recommendation in 3mensio. But if they feel, they can go with 20 also, depending on the calcification. But as a general rule, for a pre-dilatation, your balloon size should be as per the minimum diameter of the annulus. I hope it is clear to everyone.
So Rajan, we are saying even if it is a self-expanding device, you have to go with the pre-dilatation.
Yeah, so self-expanding device, so pre-dilatation will depend on the amount of calcification. If the calcification is very minimal, there is no pre-dilatation required. You can directly implant the valve because we need some kind of calcification to hold the valve at the annulus, to anchor it. उसको चिपकने के लिए कुछ चाहिए रहेगा. It's like sticky, like that calcification will act like a gum. So once you are releasing your valve, it should stick at the annulus. It should anchor. So for that you need some calcium. If that calcium is not there or it is very minimal, with pre-dilatation, if you are doing a pre-dilatation, you will remove whatever left out calcium also. So in those cases, sir, you can directly go for you can directly go for a direct implantation without pre-dilatation.
And what about post dilatation in self-expanding?
Yeah, so post dilatation, if the valve is constricted and if they feel there is a paravalvular leakage. So once you are implanting the valve, once the valve is implanted, when all your three pedals are released, they will insert a dye. So there will be a what do you call? There will be a pigtail catheter in the non-coronary cusp to take the angio shoots. So with that shoots, they will see whether the valve is expanded, valve frame is fully expanded, and if they see there is a paravalvular leakage, that is between our original valve and the earlier leaflet, the original leaflet. If in these two cases there is a gap and you can see some fluid flowing, they have to go for a post dilatation balloon. So it should be as per the average size of the annulus.
So I'm just trying to imagine, Rajan, we are talking about a nitinol frame, which is going to take the shape of the valve, or
Yeah.
Why do you need to post dilate it? And does it not go back to its original shape, or how does it work? A
No.
nitinol.
So what they say, once you have released your valve at 80%, leave the valve to expand because nitinol usually expands to the body temperature. So then you release the valve. If you feel the valve is still constricted, because if the valve is constricted, likelihood that it will hamper your effective orifice area, means the what new valve will not function properly. So you have to expand that valve with a moderate post dilatation. So once that is expanded at both the non-coronary cusp and the left coronary cusp, if the valve get expanded properly, it will stick properly and you get a bigger effective orifice area that will give you a better durability.
Dr. Rajan,
Both Rajesh, both more than nitinol, even if it is a there is a chances of 5 to 10% recoiling also.
Yes.
So yeah. When you have the recoil, you can address that with that post dilatation and ensure that the optimization of that valve.
Yes.
Thank you, Abhilash.
So that is a separate subject. We will cover it when we are talking about the TAVI, implantation. I have got some 40 cases where I can show you why they have done a post dilatation or where the valve was constricted. I have got around 400 videos, so I can show you exactly where they need to do a post dilatation.
So Rajan, in your last question from my end, since you have an experience with more of self-expanding device, is that right to say?
Yeah, you can say yes.
What percentage required a pre or a post dilatation with balloon?
So yes, so if you are doing a good pre-dilatation, 80% post-dilatation is not required. The pre-dilatation should be done very aggressively and very properly. It has to be repeated once or twice if you feel the space for the valve to be created is less. If you do a proper pre-dilatation, maximum times you don't need a post-dilatation.
Okay, Rajan, thanks.
Any other question anybody has got?
Dr. Sab, in continuation with the question asked by sir, does heavy calcification is also a cause where self-expanding will not attain its original size? Can calcium be a factor which will prevent its full opening?
Yeah. So that's why if you do a proper pre-dilatation, so it is just like you go back to your stent, because in stent we do a pre-dilatation to ensure
Yeah.
there is a space is created. Similarly, here you will pre-dilate so that whatever calcific raphe or whatever calcium was there at the leaflet, it will break. So when it
Right.
breaks, there will be a free space created, and then you will implant your valve. Then you will check again if it is not under expanded, then there is no need, and there is no any leakage or something, it is anchored properly, there is no need of a post dilatation. So that's what I'm telling. Your pre-dilatation plays a very important part. If you do aggressive pre-dilatation, 90% you don't need a post-dilatation.
Thank you, sir.
Actually, calcium is needed for self-expanding valve. A certain amount of calcium is required for self-expanding valve to choose, right?
Yes,
If it
sir,
is a
because
if it is a more fibrotic, the first preference is balloon expandable only, na?
yes, those are pure AR cases, aortic regurgitation.
Yeah.
Any other doubt? Just you can ask me, no problem. Relevant, irrelevant, it's fine.
Rajan, the question not to you, but can somebody else explain the size of the balloon needed for pre and post dilatation? How do you decide what should be the size of the balloon?
It's for the pre-dilation, it's a minimum annulus diameter, and post-dilation average diameter.
Give an example size.
So if our minimum annulus diameter is a 16, okay, and average diameter is 18, and maximum diameter is a 21 kind of thing. So our pre-dilation balloon should be 16 or less than 16, and when it's come to post-dilation, so it has to be average diameter like 18.
I presume that is right if Rajan also endorses that.
Yeah, it is perfect.
Yes, it's
Thank you, sir.
Karan, since you are there, आप भी एक बार explain करो for better understanding of everybody.
So, sir, what Rajan is trying to say, if we are taking the diameter size, as Ramesh has also said rightly, if we are taking minimum of 16 and average of 18 and I think maximum of 20, then for the pre-dilation we have to take 16 as our markup point, and the balloon size should be used of 16 or less than 16. But for the post dilation, we can take a markup size of average diameter, which is 18.
Correct.
All right, continue, Rajan. Thank you, bro.
Okay, so then the understanding of the 3mensio report, I'll just show you a 3mensio report. Just one second. Okay, so now this is your annulus. Okay, can you see this annulus? Right, we have measured this annulus here. And you can see this 40%, so it is in the systolic phase. So anything less than 50 is called as a systolic phase. So these measurements are real. Can everybody see this? Right coronaricus, non and left.
Right.
Now I'll go further here, and now you see the minimum diameter of annulus is 19.7, maximum is 24.9, and average is 22.3. So can anyone tell me what should be the balloon size here now?
It's 19 or less than
For
19.
pre-dilatation.
Pre-dilation, it's 19 or less than 19, or
So
you can
19 का
say
तो size आता
20,
नहीं है. You can go with
20,
18 balloon.
18 or yeah.
So is it clear now regarding this thing?
Right.
Yes.
Okay.
So it's a bicuspid or tricuspid?
Yeah, that I'll tell you. Now you come here and you see this is the LVOT. So this is measured usually 3 to 4 mm down. So this is again like 71. This is slightly short LVOT, but it's fine. It's not very significant. Now coming to the LCA height. Now can you see this 13.2 L?
Right.
From the annulus to this coronary opening, this is 13.2. So this, for any valve selection, this height should be more than 10.
Right.
So coronary artery height should be more than 10. And this is the right coronary artery height, this is 11.2. So no way your valve is going to, or your commissure is going to come in front of this coronary blockage.
Okay.
Okay. And now, can someone tell me what is the anatomy of this valve?
Bicuspid.
Which bicuspid?
Type A1.
0.
No, I think type
वो
0.
राफे थोड़ा स्लाइट राफे दिख रहा है.
Type 0 maybe?
It's a type 0 bicuspid because this is one cusp and this is one cusp.
Right. So slightly calcium seeing over there at the non-coronary cups.
Okay, and this is the ascending aorta, and this is the calcification at the annulus. Can you see this?
Yes.
Yes.
And this is exactly your this thing. What you call your exactly you are viewing in the angio. This is the calcification artery. So this is your
right.
Right. This is
Coronary.
your right. This is your left coronary artery.
Right.
So we will discuss more such 3mensio reports. I have got hundreds and hundreds of reports like this. We can discuss different types of anatomies. This is
So
just for your reference.
Right. So angulation be also matter, na? Angulation it's approximately 30-40 degrees.
Now this angulation is around 70 degrees. Can you see this?
Yeah, it's a
So this is extremely horizontal.
horizontal. Yes, right.
So horizontal aorta means your catheter should bend at least to the extent that it can be get placed here. So your delivery catheter should be very flexible for such cases. So this is called as a horizontal aorta, and this is called as implanter's view or aortic angulation. So there are two things. One I wanted to explain. So this angulation, can you see LAO1 and caudal 3? LAO1 and caudal 3. Can all of you see this?
Yes.
So LAO1 and caudal 3, this is called the implanter's view because they will ask you in the lab, what is the implanter's view?
Right.
So once they have pre-dilated, once your valve is at this junction, they will ask you. Here, all the three cusps are in one line. Okay. And now, once we overlap the right and the left, this is called as the cusp overlap view. So this will be always in RAO caudal. The right and the left will be overlapped. So they start with the cusp overlap view because you get the depth idea, and they will reconfirm in this view, and then they will implant the valve.
सर वापस एक बार एक्सप्लेन करेंगे प्लीज?
करता हूँ because this is new for everybody. बस देखिए, ये आपको यहाँ पे एक ये पॉइंट दिख रहा है, येलो पॉइंट, दिस वन, दिस इज द राइट कोरोनरी. उसके बाद ये दिख रहा है आपको कि ये ग्रीन, दिस इज द नॉन कोरोनरी कस्प, येलो, द ग्रीन इज द राइट कोरोनरी कस्प, और ये लेफ्ट. ये तीन पॉइंट जब एक साथ आते हैं, ये तीन कस्प एक साथ आते हैं एक लाइन में, when these are in one line, this is called as the three cusp view or implanter's angle.
Okay.
Once you overlap the right and the left, this is called becomes the cusp overlap view. तो इसमें आपको in this view the aorta becomes elongated. So usually they will start in this view only now to reduce the pacemaker implantation. So in this view they will go open the valve at 80% and confirm the depth again in this 3-angle view, and then they will implant the valve. So whenever you are in the lab, you have to write both these views on a paper and you have to paste it next to the monitor. So they will keep this, then they will save both these angles in their when they are rotating the CR.
Right.
Dr. Rajan, one doubt. In simple one sentence, the implant will be happening on RAO view, before the implant, it is confirming through an LAO caudal, right?
Yes, yes.
Yeah. Always they will implant on RAO only, right?
Yeah, because otherwise you will not get the proper depth of the device.
Right.
Okay.
Dr. Rajan,
Uh,
there was one term just to reconfirm with you, coplanar axis or angle.
so coplanar is this one which you are seeing on the left hand side. This one is the
Okay.
coplanar view.
Okay.
It's a image angulation.
Doctor Sahab, matlab caudal view will give a doctor a right direction for the depth where he
So
should place
caudal
the
view
device.
will tell you like what, because you see both these images. This is giving you more of an elongated figure, right?
Right, sir.
So this will give you more depth idea. Because earlier,
Okay.
why, if you see all the clinical trials, the self-expanding valve had more of a pacemaker implantation because this cusp overlap technique was not developed that time. Now with this
Right, sir.
cusp overlap technique, they have reduced the pacemaker implantation to 5 to 8%.
Right, sir.
RAO caudal is also known as the spider view, right?
Yes.
Yeah. So in simple, we can remember it. Implant will be happening on a spider view.
So you try to remember the three coplanar view. Implant happens in RAO caudal where you overlap the two cusps, the right and the left. And once you release your valve at 80%, you reconfirm in the coplanar view and you release the valve. Simply.
Okay.
Any doubt? Because this is very important, because this they will ask you in the lab. What is the cusp overlap view and what is the coplanar view?
Right.
So you have to write 5 things in the lab on a paper when the case discussion is over, because there are many people in the cath lab. You have to write what is the coplanar view, what is the cusp overlap view, what is the minimum average diameter of the annulus, what is the minimum diameter of the annulus, what is the average, and what is the max. So then once this is there on a sheet of paper written, the chances of any kind of complication is minimal.
Right.
I will repeat once again if not understood by any of you, or we
Understood.
can have a separate session on this 3mensio where we'll only discuss 3mensio.
Yeah, that's better, I think.
This is just to give you a basic idea of 3mensio. Many people will be seeing the 3mensio report for the first time. So anyways, I will be sharing this presentation. You can go and you can come back to me. And once we have the 3mensio license, I will show you how on a live case, how the 3mensio is done.
So then just a question, matlab what I just want to confirm what I'm understanding. During the implantation or when during the I can say cannulation, the cardiologist will be looking into RAO view.
You don't tell RAO, you just say cusp overlap view.
Okay.
So cusp overlap view will be always in RAO caudal.
Okay. Okay. And then when they take the position, then they can reconfirm with coplanar view.
Yes.
Which will
So
help them
basically, see, your this side of the valve, non-coronary side and the left coronary side, the depth should be the same, no? Because if the depth is more here, again the valve may pop out. So that is called removing of the parallax. So parallax is what? When at the NCC and at the LCC, both these sides your depth is the same. So that's why they will confirm the depth first in cusp overlap view, then they will confirm in coplanar view or the implanter view. When they find the depth is the same in both the angles, then they will implant the valve.
Okay.
So this point they may change this angulation. So what we are giving in a 3mensio is just a reference point. The physician may change it to his own view depending upon his expertise. So this is just a starting point for them. But if they fail, there is some other angulation, I feel I'm feeling better. It's up to them. It's for
Right.
our,
Okay.
we are
It's a
giving
depend on
for,
the depend
yeah.
on the their skill set where they trend and who's following.
So if I ask a question that what I need to know and what can be asked during or expected from a clinical guy that he should
You
uh,
should know
uh,
what is the cusp overlap pew and what is the three corner pew. You should know this
okay.
RAO 14. I mean, this will change as per the anatomy of the patient.
Okay, then we have to mention degree as well, RAO 14 and cordial
Yeah.
37
So
like this.
anyways, in
Okay.
this 3mensio report is already there. You have, when you are discussing, you have to mention it, write it down a piece of paper, paste it on the monitor or next to somewhere in on the cupboard or wherever they can see it.
Okay. 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 Fine.
So for
Because
this
that time you cannot open your mobile and all, you can see which is that you have to write it.
Understood.
so for this case support, we also well spots with the imaging view in the cath lab, so you can get better idea.
Okay.
So that's my.
Dr. Rajan, when we called it as horizontal aorta, means at what angulation?
So
And
if this is more than 50 degrees, it is called as the horizontal aorta. If this angulation.
okay.
Sorry, please repeat.
If this angulation is more than, now this is a horizontal aorta, this is 70 degrees, right? So if this is more than, more than what you call 50 degrees, it is called a horizontal aorta.
Okay.
And this, suppose अगर ये 30 डिग्री होता तो आपको एक vertical aorta मिलेगा. You will get which is easy to implant.
Because angle कम हो गया ना वहाँ पे.
Yes. And your even the pressure on your delivery catheters is very less.
Yes.
And Rajan, I heard in one of the conference that whenever there is an horizontal aorta, people usually prefer to pre-dilate. Is there like some correlation?
Yeah, because horizontal aorta will always have a lot of calcification.
Okay. So because it's a horizontal aorta, it will have calcification, or because there is calcium, it becomes horizontal.
Yeah, see, horizontal aorta has got nothing to do with pre-dilatation. Pre-dilatation depends on the calcium score which you have.
Okay.
Horizontal aorta will only tell you that your first and second operator has to be really skilled to ensure that, so that while anchoring it at the annulus, it is anchored properly. Because you have to manually twist, you have to manually rotate the device at the annulus to ensure that you get the proper depth. If it is not horizontal, if it is a vertical aorta, it's very easy to place the device. But if it is horizontal, if your delivery catheter is not flexible, then you will face challenges. So that was the case with the first Medtronic valve, core valve, and the Evolute 1 series. Their delivery catheter was not flexible. So their doctor has to really do lot of maneuvering to reach to that annulus and to, proper synchronization between first and second operator. One has to hold the delivery catheter and other will rotate. And once they achieve that position, they will release this valve. So this usually horizontal aorta will take another 15-20 minutes to anchor at the annulus.
Okay, got it. So there is nothing like, there's no protocol per se as such. If it is an horizontal aorta, you need to pre-dilate.
No, nothing like that.
Dr. Rajan, it is called as horizontal aorta is complex case. So what in terms of complexity it is?
See, horizontal aorta, if it is now complexity is, suppose the angulation is more, it is a complex because you have to actually rotate your device. Your device should be flexible enough to rotate at that point. So if you see the Vita Flow Liberty Flex, this will be advantageous in horizontal aorta because there is some steering mechanism which can rotate at the annular. So now the next version, all companies are working towards. Today, maximum thing is you have to manually rotate it and you have to angulate it. First thing. Secondly, horizontal aorta with a type 0 bicuspid is again one of the difficult anatomies to treat because already the calcification is very high in type 0 bicuspid. Plus you have a horizontal. So even while pre-dilating, you have to be careful. And again, anchoring will become a challenge because there are only two cusps. These two cusps will not allow the valve to open properly. Plus, you have to manually rotate it also. These are the challenges.
So does it related to paravalvular leak, means chances of increasing paravalvular leak with?
Yes, if paravalvular leak is more related to the calcification of the valve. If the valve is more calcified, if after implantation there is a leakage, it is not sealed properly, you have to do post dilatation.
Not related to horizontal aorta.
No, no, no. Paravalvular leakage and horizontal aorta, there is no connection.
Got it. Thank you.
In
Our last live case was, Dr. Andrew has done. It was a horizontal aorta, and he didn't predilate it. He directly, placed the valve. If you remember that live case.
Yeah, because that calcification was very less in that case.
Yeah. He has directly valved it, and then he did the post dilatation.
Because the valve was constricted and there was mild paravalvular leakage there, so he has to post dilate.
Yeah. For the optimization.
Yes.
Paravalvular leakage is only related to the optimization. Any shape of the aorta, the PVL can happen.
Yes.
To prevent the paravalvular leakage, you have to be aggressive on the post dilatation.
Okay. Now this is your, what do you call, these are your femoral vessels. So as I told you, exactly at this puncture point, the mid of the femoral, you have to take your puncture for the sheath. And then from here and from this left coronary artery, all your other equipments like your pigtail catheter, your balloon pacing tip will go from this. So this is like this should be more than 6 for our device. For any, and plus the calcification also matters. So in this, you can see in this femoral there are no calcification, so less chances of any femoral rupture. And just you can see this cross sectional view also. So I think all of you have understood the basics of 3mensio now. The importance of 3mensio.
Yes.
In annulus, in LVOT, aortic angulation, the cusp overlap view, the 3 planar view, and pre and post dilatation, and the femoral vessels. So this in short, plus there are many other things to be learned in the 3mensio, but as we go case by case, it will be easy. This is just a starting for many people. I'm just showing what are the basic features in 3mensio. They will ask you. Okay, everybody's fine?
Yes.
Yes.
Can you all see my screen?
Yes.
Okay, now since I have purposefully made this slide, because since we are, we are, what do you call, we are in a launching phase, there are some cases where I'm not telling you say no, but be careful in selecting the device or be careful in selecting the patient. Now, first is the severe calcification. So severe calcification, why? Because a severe calcification may lead to more paravalvular leakage. Then secondly, something is called as a porcelain aorta. Now, what is porcelain aorta? Where the entire the ascending aorta, descending aorta, and at the annulus, it is full of calcium. So these cases has to be rejected. Where there is minimal or no calcification. Now, if there is minimal or no calcification, the valve may slip down or it may pop out. Pure AR cases means there is no calcification at all. So this ideally should be done by a balloon expandable valve. Horizontal aorta we already seen. When there is heavy calcification in LVOT, if there is heavy calcification, because LVOT is your landing phase. So if there is heavy calcification, again the valve may pop out or the valve may become constricted. You have calcified femoral vessels, bicuspid anatomy, and short intramuscular septum. So these are the cases I'll show one by one. Let us discuss in detail. Now, can you see this? This is called as a porcelain aorta. So these cases should be rejected at the initial level when we are launching a device, because this may cause stroke to the patient. because maximum cases we are not using the embolic protection device. Then comes the horizontal aorta, because your system should be, I'm not telling you should reject, but we have to be careful in selecting, because first time operators will be using, so we have to tell them it's horizontal aorta, sir, be careful. Thirdly, when there is heavy calcification in LVOT, can you see this calcification in LVOT? This one, just see my pointer.
Yes.
So this is this reduces your area of LVOT because of the calcification, and your valve may pop out. It may pop out. It will jump up.
Okay.
So
Doctor, can we measure the calcification percentage?
yeah, we can measure that. That is a separately in 3mensio you can measure. That is called calcium quantification.
Yeah. Even CT report also shows calcium score sometimes.
Then comes your short intramuscular septum. Can you see this red line here? All of you, this one, the blue arrow and this red line, MS. It is written MS. So if this is short, then and this is your landing phase of this LVOT, you are going to disturb the left or right bundle branch. So again, chances of pacemaker implantation are high. So if there is short intramuscular septum, just inform your physician this is a short. There may be a chance of pacemaker implantation.
Okay. So Rajan, just one question. When I'm looking on the practical aspect, then this depth of 1 or 2 mm, what it is totally dependent on eyeballing of the consultant who was doing, or we have
No,
some.
so yeah, so it is not eyeballing. So now the earlier versions were not having any marker on the system, a marker on the valve. So now that's why companies are coming up with markers. So that marker will tell you what is the depth of the valve.
Okay.
So
Okay.
like suppose
We
in
have marker.
Navitor, the marker is exactly 3 mm above the annulus. So you can go 3 mm deep into the LVOT. So the marker should be exactly at the annulus, so that once that ensures your valve is 3 mm into the LVOT.
Got it. Got it.
And how we come to know about this intramuscular septum, means its thickness or its position?
That is measured in 3mensio report.
Okay. It is mentioned there.
Yes, you have to calculate it.
Okay.
Now, many companies will don't mention, but usually I made it a practice of we should mention it.
Yes.
Because tomorrow something goes wrong, we can tell, sir, it was short. I already informed you there is a chance. So be very, very honest while doing your case.
I read 2-3 mentions. They were not mentioned. So I
But I
asked.
usually mention because in the latest version of the 3mensio, there is a mechanism to measure the intramuscular septum.
Okay, got it.
Rajan, I'm going to ask you to digress a little, if possible, using this particular image. We have been talking about incidence of increased chances of pacemaker implantation if we go a little deeper in the aorta, right? So just for everybody's benefit, if you can slightly throw a light in layman's language, why do we say कि valve लगाने पर अगर आप ठीक से उसको implant नहीं करते हो, deploy नहीं करते हो, or you go slightly deeper, the pacemaker लगाने के chances बढ़ जाते हैं.
So, sir, it's a good question. So you can see this septum here, this red one. So this is exactly between the right coronary and the non-coronary cusp. So if this is your target line. So if you go below this target line, you have the bundle branches, the right bundle and the left bundle branch of the conduction system. So once your valve goes deep, you may hamper one of these bundles, and the circuit become disturbed, and you need a pacemaker, because that electrical impulse gets hampered. So just below this muscular septum, you have your bundle branches. So you can cause a right or left bundle branch block.
So you want to say that the red line which is showing as MS, which has
Yeah.
been arrowed. So up to that deep.
Up to this point, you can go deep, 3 to 4
Okay.
mm deep here.
Okay, and below that it would be
Below that, see,
a
I have
chances of.
seen cases where 6 to 7 mm deep also, if you go, there is nothing has happened. But there is a chance if you go 5, 6 mm deep, you may, if you are not hampering the bundle branch, no problem. But the idea is to keep it 3 to 4 mm because that is the point where the bundle branches are not to be seen. You
And the calculation of MS.
exactly below this MS muscular septum, your bundle
Hmm.
branches will start. So that may hamper your bundle branch. If you hamper that bundle branch, you may land in blockage, blocking that branch.
Okay, and as if you said that this MS can be calculated with the help of 3mensio report.
3mensio report.
It has to be calculated manually, or
no, by drawing only. By drawing, you can draw that. We can see in that figure. So for that, you have to inform your radiologist that whenever they are taking a CT angio, both the ventricles should be filled at the same time. Then only you will get this muscular septum. Otherwise, you will not
so
get it.
both the ventricles
should be filled at the same time. जब वो contrast डालते हैं ना, तो
हाँ.
contrast in both the ventricles should go at the same time.
Okay. Okay.
Anyway, we will discuss more 3mensios. You will understand that time when I am sharing more 3mensio reports. Okay, I think you are fine. Now coming back to the disease and progression. So like, as we told, as the age increases, there is calcium deposition on these leaflets and the valve becomes stenosis. So that we call as an aortic stenosis. So this is not happening in one day or 2 days. It is a progressive disease. It happens over a period of time. So as the age increases, the prevalence increases. After 80 years, the prevalence is 9.8%. This is a global. This may differ from country to country, the progression of the disease with age. So what are the symptoms? As everybody knows, angina, you will face the chest discomfort, fainting or dyspnea. And many times the patient is also asymptomatic. So most of the time aortic stenosis is diagnosed when they do an echo, accidental echo. And in that echo only, you have to observe two things. One is the AVA, that is the aortic valve area, and the mean gradient. So that I'll come to how to observe that. So what happens if you leave it untreated? 50% will not survive, and after 5 years, there is a chance that 20% of the patient will remain. So this they had developed when they were seeing the survival of the patient who are left untreated with aortic stenosis. So how to diagnose? Like first is the ECG, then you have this echo, CT, then you have this angiogram, stress test, and the normal stethoscope for physical examination. So as I was telling, in a echo report, if the aortic valve area is 1.5 and above centimeters square, it is normal. There is no stenosis. If it is below 1.5 centimeters square, it is mild to moderate. 1 and less than 1, it is called as a severe aortic stenosis. Okay, so these measurements you will get on a echo report, 3D echo report. So this aortic valve area and effective orifice area don't get confused. It is the same thing. So more than 1.5 and above, it is normal. Below 1.5, mild to moderate. Less than 1, it is severe. Is it clear or should I repeat? I hope all are fine with this.
Yes, Rajan.
Yeah.
Now the mean gradient. So what is a gradient? Gradient is the pressure from which the blood is flowing from the aortic valve into the LV. Or sorry, from LV into the aorta. So if the gradient is below 20, it is mild stenosis. If it is between 20 and 40, it is moderate stenosis. More than 40, it is severe stenosis, mean gradient. It is the pressure. These are the pressure gradients. So it is like you take a funnel And if you decrease its size, obviously the pressure will be more. And if you widen the size of the funnel, the pressure will be less. Like when we are gardening or watering the plants, if I want to water a plant which is far away, I'll just put my finger on that nozzle, so that water becomes slightly thinner and it can reach, uski dhar बढ़ जाएगी. So because in that case, what I have done, I have decreased the area, so the pressure is increasing. So this will be, you can easily get on the echo report. So after valve implantation, this transthoracic echo should be in a single digit gradient. It should be from 2 to 9. Then only you can tell it's a successful TAVI implant. This mean, this mean gradient should be in single digit post TAVR implantation. Is it clear, or should I explain once again?
Clear.
Okay, anyways, when we study some clinical trials, you will understand. But understand your effective orifice area, the AV area should be more than 1.5, and the mean gradient should be in single digit. That ensures you have done a successful TAVI procedure. Now, these are the STS scores based on the surgical risk. Now, in clinical practice, nobody is using it now. These were doing it for a clinical trial. So STS score less than 4 is low risk, 4 to 8 is intermediate, 8 to 5 is high risk, more than 15 is prohibitive risk. So if you see in our trial, the STS score is more than 8. So we have included all high risk patients who were risk for a surgical procedure. So that ensures your device has performed well in high risk population. So that is the risk stratification chart. That is called the STS score. So there is also an online STS score. You can put all the patient details. You can automatically get this score as per the American Heart Association. So what today options we have for treatment? We have medical management, balloon valvoplasty, surgical, and the transaortic valve. This is the new therapy which is growing up, because no one likes any kind of surgery. So better we should go for a minimal invasive surgery. So with that, I conclude my presentation. If you have any doubts, I am happy to clarify.
Rajan, thank you. It was really good, very informative, and I think we should maybe repeat this once again, not immediately, but maybe in a span of some time. But if you ask me, it was really informative. I mean, a lot of new
Yes, thanks.
stuff came up, and
so what I had to do is, one module is for basic training and 3mensio. The next module what will we have is the TAVR procedure step by step, how they do, and the associated complication. And the last module will be your competitive analysis, like compared to other valves, how we are placed in the market, what are our technical advantages, pros and cons of the procedure, and how to manage a complication. So that how I have designed. But if you want to repeat, we can repeat this also once again, no issue.
just one question, Rajan. I saw the simulation on the Mentis simulators that they have. You think that adds value with some physicians, or in the initial phases we need to have something like that, or you think it's
Yes. So that will have, because we will be having many new physicians, the medical colleges and all to target, because everywhere we so it will give a feel of the device. So that stimulator will have different kind of anatomies: type 1 bicuspid, type 0 bicuspid, tricuspid anatomy, horizontal aorta. So they can feel the device in that, how the device rotates, or how the valve, when at what depth they need to release. So it's beneficial. Every company is having it. So like
How much user friendly it is?
no, that depends because Abbott was not at all user friendly. What I experienced to setting up, we require 2 3 people because you have to pour some water and all in it, and there are so many adjustments to be done. So it takes around 1 hour to what do you call it, to set up the entire thing. And again, it has to be in a training village. We cannot keep it on a stall because it takes a lot of space actually. So we can keep it for India Live and all like big conferences or Sentient or India Live where we have a separate lounge. People can come try their hands on.
Okay. And how close does it resemble to the actual procedure that is being done?
No, actual procedure is very different. Like there is a lot of vast difference.
That's what is it? 30%, 40%?
Yeah, it's almost all varying will be 40%. Because what they have created is a silicon material. With the silicon material and what we are observing our valve, no, it is slightly different. Obviously, like वो टेस्ट राइड में और ड्राइव करने में थोड़ा फर्क तो आएगा ही रोड पे.
No, I understand that because I saw, I think Merrill has that in one of
Yes.
their
No,
training villages.
everybody is having now.
SMT also has it,
Yes.
right?
Boston too.
Yes, Boston. Everybody is having.
Well, thank you, Rajan. I don't know if there are any questions, then you will have to take it. I'm good. Thanks.
Let me know if anybody has got any questions related to the anatomy or 3mensio. I hope I made it very easy to the best possible level. What
Yes,
I can
right.
say.
Yes, Rajan.
Yes, very informative, very useful.
Agreed.
राजन भाई, ये अभी आज का सेशन का ये क्वेश्चन नहीं है, लेकिन जैसे हमारे जो प्रोडक्ट का जो पीपीटी है उसमें अपना डिलीवरी सिस्टम में 360 डिग्री लिखा हुआ है. सो इट्स विद द लिबर्टी और लिबर्टी फ्लैट, तो
नहीं
वो
वो
कंफ्यूजिंग
लिबर्टी
है.
नो वो 360 डिग्री का है ना. वो एरोटिक आर्च के लिए, दैट इज फॉर द एरोटिक आर्च, नॉट फॉर द एनुलस.
हाँ, सो वो
That
अपने
will come in flex. That will come in flex. What you are telling, no?
ओके,
That annulus it will
या
rotate. That will come in flex, not in this device.
ओके ओके, बिकॉज वी आर डूइंग रेगुलरली सेशन विथ आवर वेस्ट टीम, सो दैट इज अ वन थिंग वी आई वांट टू अंडरस्टैंड. वो जो 360 डिग्री वाला है, इट्स नॉट इन लिबर्टी, इट्स लिबर्टी फ्लैक्स आई थिंक.
Flex. Yeah.
या थैंक यू ब्रदर, थैंक यू.
So anyway, we will be sharing this slide and all. If you have any doubt, please get back to me.
Sure, Rajan.
Because unless you are, if you are sound with the 3mensio report, then 80% things you know, and 20% will be valve loading and how you support the physician. Now, most of the physicians they know how to do, but like if you feel the anchoring is not proper, the operator has gone too deep, you can always tell them, sir, please retrieve the valve or do it once again. You have to be slightly prompt in that. So that's why this 3mensio, because 3mensio will decide what balloon size you need to have and which wire you are going to use, what as an additional backup you need to keep, whether it is a pacemaker, stent or a snare. So that is very important. So once you know the 3mensio, you are 80% done in this field. So I hope there are no questions. So can we wind up, or still anybody has got questions? You can always get back to me.
Thank you, Rajan.
Dimple, you want to say something?
Yeah, I was just waiting for everyone, if there are any questions. Otherwise, we'll have a closing remarks, Rajan, and we'll wind up. Anyone would like to take up a question, or we end the session? Yeah, I think Rajan, it was amazing and a quite informative session, and we really look forward for many such session coming up in future. I'm sure people have really loved it because we discussed about 1.5 hours. It's almost close to 2 hours, and people were still asking for there were a lot of questions, a lot of interactive thing which was happening, and that's really amazing. Um, also, team, as I said that I'll be sharing this recording to all of you guys. it can't happen that we expect everyone to just know about the technology or the science in one go. Of course, there are a lot of self reading which is needed. So guys, when I'm sharing this recording to you, please go back, do some self reading, and I'm sure in next session you would be having more question, and it would be more clear for you. Also, Rajan, Dr. Rajan, I would request you that since this was done in bit hurry. I
Yeah.
could not give time to you to share it with me, the PPT. But
Yes.
in coming session, since it would be next Saturday, I would request you to share across the PPT to me maybe 2 or 3 days prior, so I can share it with team and they can go through it before they come and attend the session. So
Sure.
we may have more questions and more clarity for the benefit of all, right?
Yeah,
So
yeah, yeah.
guys, as I said that there are many more sessions which are lined up, and we will be meeting more regularly with live cases across India. So it's going to be a training. I would say more training in 2025. So get acquainted, and I would say get used to for this, and it's going to be very exciting year for 2025. So thank you so much, Rajan, for taking out time, and thank you guys for attending the session, and all the best for you. Thanks a lot.
Yeah.
Rajesh, any closing remarks from your end?
Sorry?
I said any closing remarks from
No,
your
no,
end?
just I want to thank everyone for their interactive, good questions and all. And I know many people would have been seeing this for the first time also, 3mensio. But only thing is, there is only one line. Today, don't know the next point, you will know more. So, more and more cases you see, the more and more confident you will become.
Sure. Thank you, Rajan.
And after attending 350 plus cases of TAVI, I will say the 351 case will be a new one because every patient is different, every patient is a new subject. But
True.
your prior experience will help you in understanding that case very well. That's what I mean. So I never say I know TAVI very well. I'm still learning. That's what I'll say.
Absolutely. Rajesh, any closing remarks from your end?
No, as I already said, Dimple, all good. Just next time, if people can come a little more prepared because we want more participation. That will help Rajan also to upgrade his knowledge and
Yes, boss. We'll
prepare for
surely
the
do
next.
that.
Okay.
Yes.
Thank you, Rajan. Thanks, guys. Have a
Thank
good day.
you. Thank
Thank
you,
you,
team.
Dr. Rajan.
Thank you.
Thank
Thanks,
you so
Raj.
much.
Thanks.
Thank you.